Thank you for joining us today for our training, Building a Better Suicide Risk Assessment, the nuts and bolts of the Columbia Protocol, hosted by the Center of Excellence for Behavioral Health in Nursing Facilities. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and it is my pleasure to oversee the delivery of mental health and substance use disorder trainings and education to nursing facilities nationally at no cost to the nursing facility. We have a few housekeeping items as we get started. This session is being recorded. All lines are muted. You can use the chat box to place questions and comments, or use the raise your hand option to be taken off of mute during the Q&A portion of the training. If you have not completed the pretest survey, we ask that you do so now. The link is in the chat. Near the end of the training, we ask that you complete the post-test evaluation, which will be shared as we conclude today's training. Your feedback is appreciated. The slides are available to you on our website. However, I will place the link in the chat during the presentation. Now, it is my pleasure to introduce our presenter for today, Mr. Adam Lesser. Adam is a licensed clinical social worker and assistant professor of clinical psychiatric social work in the Division of Child and Adolescent Psychiatry at Columbia University, a lecturer at the Columbia University School of Social Work, and the deputy director of the Columbia Lighthouse Project at the New York State Psychiatric Institute, where he assists with all suicide prevention activities related to public health, including international dissemination and implementation of the Columbia-Suicide Severity Rating Scale. He has published, presented internationally, and consulted to state and local governments on best practices for suicide risk identification and prevention, and has trained over 100,000 individuals on these methods. I am happy to turn it over to Adam to begin the presentation. Thank you, Adam.
Thank you, Nikki. It's a pleasure to be here. Good afternoon or morning. I'm going to share with you a presentation today on the Columbia-Suicide Severity Rating Scale, how to use it for assessment of imminent suicide risk, and we'll cover also some basics about suicide prevention in general. Before I start, though, I always remind my audiences that suicide is a very personal topic. Many of us are survivors who miss our clients, our friends, our family, and some of us are survivors of suicide attempts. So I want you to pay attention to how you feel today. If during the webinar you need to take some time for yourself, please feel free to step away from the computer. And I want you to do something nice for yourselves this weekend, because we don't pay enough attention to taking care of the caregivers. And when we don't take care of ourselves, we burn out, and then we can't do the amazing work that you all are doing. We also know that clinicians and healthcare workers feel an obligation to appear healthy or invincible, and maybe hesitant to ask for help. The biggest risk for employees is vicarious or secondary traumatization. When you hear difficult stories, that can transfer the trauma from the client to the counselor. And we're also vulnerable to compassion fatigue, because we have empathy because that's necessary in our jobs, but it also makes us at risk for compassion fatigue. Studies actually show that depressed clinicians are more prone to making errors and have a higher risk of chronic illness. So you are uniquely positioned to recognize depression and burnout in yourself and in your peers. So on to suicide. Suicide is actually a global public health crisis. It kills more Americans than car crashes, more people across the world than natural disasters, war, and homicide combined. It kills more soldiers than combat, kills more teenage girls across the globe than any other cause. It kills more firefighters than fire and more police officers than crime. And we used to think that each suicide affected 6 individuals who were close to the person who dies: mother, father, sister, brother, child. But it turns out that recent research shows that about 135 people are impacted for every suicide death. And those effects can linger across generations because of the silence that often follows. But there was good news, or so we thought. Suicide decreased a total of 8% during COVID, but that was only among white Americans. And in 2021, it went back up 4%. And in 2022, it went back up another 3%. So we've lost most of the reductions that happened during COVID. The good news, though, is that we saw a decrease in 2022, 8% for youth, but most of the increase has been in males between the ages of 15 and 24. Now, we lose about 45,000 to 50,000 adults every year to suicide. But for those 44,000 deaths, there are 1.2 million attempts. So there are on average 25 attempts to every death. It's actually that there are roughly 10 attempts to every death for the elderly population and about 100 attempts to every death for youth. So the numbers of people who are thinking about suicide and who are making attempts far outnumber those who will actually die. And one of our challenges is figuring out which of those folks who are having thoughts about suicide are at greatest risk. And that's where the Columbia Protocol can come in handy. As far as youth and young adults are concerned, we know about our high schoolers and their thoughts and behaviors because the Centers for Disease Control surveys them every other year. And what they tell us is that about 6% of your average high school boy and 11% of your average high school girls will attempt suicide each year. So if you have a classroom of 40 kids, roughly 3 kids in that classroom will attempt suicide every year. Usually it's 2 girls and 1 boy because girls attempt suicide twice as often as boys do. But boys and men actually die by suicide 4 times as frequently as girls. And there are a couple reasons for that. The first is that for boys and men, there is still a greater stigma against asking for help than there is for girls. We see far many more girls that have been help seeking than we do in the boys. The other thing about men and boys is that they tend to choose a more lethal method when they make their attempts. They tend to choose using a firearm or hanging, and girls tend to choose overdoses in medications. And finally, what causes more deaths in men and boys than in girls is that for men and boys, depression doesn't look traditionally like someone you would expect to be depressed. For boys, it tends to look more like an aggression or a conduct disorder, impulsivity, and not the withdrawal and isolation and down attitude that comes with traditional depression. Now, there's a strong connection between chronic medical illness and suicide. We see suicides, we see 10% of our suicide deaths have a chronic medical condition. For young people who live with a chronic illness, they're about 3 times more likely to attempt suicide than their healthy peers. And there have been 17 chronic medical conditions linked to increased risk for suicide. They include pain disorders, brain injuries, cancer, epilepsy, HIV, sleep disorders. And in cancer, suicide is most common in the first 3 months after diagnosis, with an overall risk of twice that of the general population. Now, there's also a strong connection between suicide and addiction. We see opiates in 1 out of every 5 suicide deaths and acute alcohol intoxication in 1 out of every 4. And so if you have an alcohol misuse disorder, you're at about 10 times greater risk for suicide than your peers. And if you're an injection drug user, you're at about 14 times greater risk for suicide than your peers. And up to 40% of patients seeking treatment for substance abuse issues report a history of making a suicide attempt. And it turns out that a lot of our opioid overdose deaths that we've been seeing in the past decade have not been accidental overdoses, but in fact have been suicides. One of our colleagues, Dr. Maria Okendo, did a deeper dive looking at these opioid overdoses and found that the vast majority of them are in fact suicides, and they don't get identified as suicides by medical examiners because they don't always know about the motivation behind the overdose. But when you look a little bit deeper at what was going on for those persons, you find that there are quite a number of them that are in fact suicides. And it makes sense when you think about it. What gets people into an opioid overdose, opioid addiction, is often a chronic pain issue. They get prescribed opioids by their primary care doctor or a pain specialist, and they become addicted. Or they might be self-medicating a mental health issue. They might have anxiety or post-traumatic stress disorder, and they might be using opiates to try to feel better instead of the medications that we know will help them feel better. Now, risk factors in long-term care facilities include depression, the duration of their residence. It's usually in the first 12 months. Half of suicides in long-term care facilities happen in the first 12 months. About half of them have a decline in physical health, either hearing, eyesight, speech, or mobility. About a third have a documented history of suicidal behavior, and high staff turnover is a risk factor. Now, while the greatest numbers of suicides happen in our cities, the greatest rates of suicides happen in the rural parts of our country. And there are a couple reasons for that. The first is that they tend to have populations spread out across a great distance, and that can give them poor access to quality mental health care and medical care. Sometimes the closest provider can be an hour away. And when I was training recently in Alaska, they told me sometimes it can take them 3 hours to get to an emergency call if it's out in the very frontier parts of the state. And so we see that it can be very difficult to get care when you're living in a rural area. The other thing about the rural parts of our country and suicide is that if you track all the demographic factors and measure them up against suicide rates, the one that most closely matches are rates of gun ownership. The more guns there are in a community, the more suicides we have. And this is a look at the states with the highest rates of gun ownership, where there are guns in half the homes, comparing them to the states with the lowest rates of gun ownership, where there are guns in 1 out of every 5 homes. And when you do that, you see that the suicide rate per 100,000 is twice that in the states with high rates of gun ownership, 18 compared to 9 per 100,000. And almost all of those suicides for both men and women, almost all of the extra suicides are in fact firearm suicides. So just living in a community where you have quick access to something that's so lethal as a firearm is going to increase your risk for suicide. And it's not gun ownership that increases your risk for suicide. It's unsafe storage of your firearms that leads to risk for suicide. Now, suicide's biggest cause, we know, is a heritable treatable medical illness called depression. 85 to 90% of people who die by suicide have an untreated mental health problem, and depression is the result of changes in brain chemistry. Depression is also now the #1 cause of global disability. At any one time, 8% of the world has a significant mental illness, and during COVID, we saw that the prevalence of stress, anxiety, and depression across the world was quite significant. About a third of the population had either stress, anxiety, depression, or more than one of those. And these effects are compounded for groups that are already vulnerable. Low-income families are hit the hardest. They have fewer resources and access to care, and so rates of suicide and attempts have been rising faster among Black youth than among white youth. Children age 19 were more likely to die by suicide if they're from communities where they're living in poverty, according to JAMA Pediatrics. And limited access to support and lack of in-school counseling has disproportionately impacted our LGBTQ youth, especially if they come from an unsupportive family. And so we know that suicide touches everyone, and that makes it a vital part of health and wellness for employees and their families. We need to screen everywhere and care for the caregivers. Depression is actually the #1 cause of work-related absence and costs our workplaces $23 billion a year in lost productivity. So when you can keep your employees healthy, you can actually improve your bottom line as a business. And it's why a lot of major corporations have been coming to us and asking us to train their EAPs, because they want to make sure that they know what's going on and can offer the assistance to their employees that they need to do. And so when someone uses the Columbia Protocol, like for example, firefighters, they don't just use it in their jobs, but they also use it to screen coworkers and to screen their family members who might be at risk for suicide. And why is screening so important? Because stigma and misunderstanding can be lethal. People feel like they're weak if they ask for help, or they're broken. And the stigma is even greater for people who do very high stress jobs. People like first responders, people in the military, ER doctors. We need to change the culture so that manning up and seeking help are synonyms for each other. And so people feel that asking for help is a sign of strength. And these misunderstandings can actually be lethal. When Netflix aired its drama 13 Reasons Why, which is about a young high school girl who dies by suicide, and she leaves 13 cassette tapes for people she feels mistreated her, we saw a spike in teen suicides. And that's from what we call the suicide contagion effect. That's where someone is exposed to the suicide of another person, and they're already thinking about suicide. And this exposure to someone who dies, whether it's a celebrity, a fictional character, someone in their family, or a peer, when they get exposed to someone else's death, it increases the chances that they'll make an attempt. This is especially true for adolescents and young adults. And we know that antidepressants save lives, and not treating depression is what kills people. Autopsy studies after suicides have been associated with no treatment or non-compliance. And we saw suicides drop dramatically after the invention of the modern antidepressants in the 1990s. Then in the year 2000, we saw suicides start to creep back up again. And that was when they put the black box warning on antidepressant medications that said these medications may cause you to be suicidal. People became afraid to take the medications, and doctors became afraid to prescribe them. And in fact, all of the research, and Dr. Posner, the first author of the Columbia, was tasked by the FDA to make sense of this information, this data. It turns out that it does not increase your risk for suicide at all, taking an antidepressant. In fact, there are more suicides in the placebo group than there are in the antidepressant groups during these research trials. And what can happen when you start to take an antidepressant is you can start to feel a little bit more energy. And when someone who's thinking about suicide all of a sudden feels a little bit better and like they have some energy, it can give them the opportunity to make a suicide attempt. And that's what we were seeing. But antidepressants do not make you more suicidal. They are the #1 first line intervention for treating depression. Unfortunately, people who need treatment aren't getting it. We see the undertreatment of suicidal ideation and depression and other mental illnesses is pervasive. About 50 to 75% of people who need treatment get no treatment or inadequate treatment. Over 80% of adolescents who die by suicide never got any kind of consistent treatment prior to their death. And in long-term care, 63% of residents who died from suicide and were diagnosed with depression were not on medication for that depression. So there are a few myths about suicide I want to go over. The first being that if someone's really suicidal, they're probably going to kill themselves at some point, no matter what you do. You can't stop someone who really wants to die. Multiple studies have shown that actually 93% of suicide attempt survivors, including those who make very lethal attempts and survive them, don't go on to die by suicide later in life. They'll never attempt again. Most people who are suicidal for a short period of time. It's one of those symptoms that comes and goes with levels of stress. And when your coping becomes overwhelmed, that's when you're at risk for making a suicide attempt. So if you help someone through a suicidal crisis when they're feeling their worst, it can be life-saving. You might make a lifelong difference for that person. Asking a depressed person about suicide may put the idea in their heads. This is the number one reason why people don't use the Columbia Protocol. They're afraid if I start to talk about this with someone, maybe they're going to go ahead and do it. But all of the research shows that that's absolutely not the case. There's no risk in talking about suicide with someone. This is different than the contagion I talked about a little bit earlier, where you're exposed to someone else's death. This is just talking about suicide. It does not make it more likely that someone will make an attempt. It's more likely to be experienced as relief because they can finally talk about it with someone. And the greater risk, of course, is when we don't ask these questions when we need to. Someone making suicidal threats won't really do it. They're just looking for attention. We know that there are people who talk about suicide and express thoughts about wanting to die quite regularly. This is common in folks with borderline personality disorders, for example, but they are at risk for suicide. The time that you don't ask them what's going on when they are making these statements may be the time that they feel like nobody cares, and they may then go ahead and make an attempt. We have seen that. And so even if you think they're just crying for help, you need to offer them that help whenever you hear anything about suicide. There's no point in asking about suicidal thoughts. If someone's going to do it, they won't tell you. We know many folks will tell you when you ask them, and it's because ambivalence is characteristic in 95% of people who are suicidal. It's why we see about 80% give hints or warnings to friends or family. And those hints or warnings can be very blatant. We lost a youth to suicide in one of our private schools here in New England, and they told their lacrosse teammates that night that they were going to go home and kill themselves, and they didn't do anything about it, and we lost that student. But they can also be very hidden. They can be things like reading or writing poetry that have death themes, or doing very dark and disturbing art. So you want to be on the lookout for any kinds of hints or warnings that somebody might be thinking about suicide. Then if you stop someone from killing themselves one way, they'll probably find another. This is the argument for mean safety. Mean safety is the most evidence-supported suicide prevention method we have. And what that is when you put a little bit of extra time in the way of someone who's thinking about killing themselves, and when they have the lethal means in their hands. When you can make it take just an extra couple minutes, you actually stand a good chance that that person will change their mind. So in the late 1950s, they used to use a very toxic coal gas in their stoves in England, and they started replacing that with natural gas. And when they did that, they cut their suicide rate by asphyxiation by a third, with just a very small increase in other methods. So it brought their overall suicide rates down. Then in England again in 1998, they recognized they were having a problem with Tylenol overdosing. So they passed a rule there where they have to sell Tylenol now in blister packs, where you punch the pills out one at a time. And when they do that, and it takes just 2 minutes to get a lethal handful of Tylenol, they reduced Tylenol overdoses by 44% over the next decade. Right? We buy Tylenol in bottles of 500 at our big box stores. We don't have the same efforts at making it a little harder to get a lethal means that other places have. And then in Israel, in the military, for example, in 2006, they recognized that they were losing military soldiers to suicide when they were home on leave. And so now when a military person goes home on leave, they can't take their guns with them. They have to leave them on base. And when they did that, the suicide rate dropped 40% in their military. And we know people want to be saved because survivors tell us that. We work a lot with a man named Kevin Hines. He's a wonderful person who's a motivational speaker now, who survived jumping off the Golden Gate Bridge. And what he says, he tells his story. He was 19 years old. He had a psychotic depression. Voices were telling him he had to die, but he made an agreement with those voices that if just one person asks me what's going on, I'm going to tell them everything and I'll get some help. But he goes to the bridge and he's crying the whole way there. Nobody says anything. He walks across the bridge. Finally, a woman is coming towards him and he thinks, this is it, I'll get some help from her. But instead she says, will you take my picture? And so he takes her picture a few times, gives her back her camera, decides it's hopeless, and he jumps. And what he says now is that instantly, as soon as his hands left that railing, he realized he had made a mistake. And everything in his life he thought was unfixable was fixable, except for what he had just done. He had instant regret, just like most survivors tell us that they did. And he says now we need a culture where people aren't afraid to ask questions like this. And approach someone who doesn't look quite right and ask them what's going on. And so that's why we're putting the Columbia Protocol questions everywhere people acquire lethal means. So they can be put on posters in bathrooms, they can be put at points in our national parks where people typically die by suicide. We've trained transit workers in our subway stations. We've trained pharmacy students in pharmacy college so that they can ask when they're prescribing, when they're filling a prescription for someone and the person doesn't look quite right. And we've done projects with gun shop owners because they don't want to sell a gun to someone and find out it was used in a suicide. So they've been very receptive to the idea of putting the Columbia questions up on a bulletin board in their stores, for example. And all of this is a movement away from the medical model or a synergy between the medical model for suicide prevention and the public health model. We used to just take a medical approach to suicide prevention, where we identified people who had risk factors and we screened them and we offered treatment by mental health professionals. But most people at risk are not in treatment, as I told you earlier. And so now we know that we have to take a public health approach. We have to target whole communities, do universal screening, train all gatekeepers across all health services. And we got this idea, the first ones to do this were the US Marines. They came to us for training, but they didn't ask us if we would train their clinicians. They asked us if we would train their financial aid counselors, their chaplains, and their lawyers. Because the number one precipitating event before a Marine suicide is having a legal problem. They get arrested for a DUI or a domestic violence charge, and they're ending their lives by suicide because of the impact that can have on their military career. So now in the Marines, every time a Marine meets with a lawyer, the lawyer screens with the Columbia screener and then escorts the Marine to behavioral health if they have a high-risk answer. And the Marines were able to reduce suicide by 22% in the year after they underwent this training process. So we must find people where they work, live, learn, and thrive because they don't necessarily have the will to come to you. We know that 75% of those who die by suicide die at home. For our youngest kids, it's about 95%. And so screening normalizes this conversation. And we need to change the culture so it becomes like taking your blood pressure where everybody gets asked. It's why we created these community cards. They have the Columbia screener on one side and instructions for what to do if there's high risk. And on the other side, they have an instruction for different groups of people. So we have them that say, ask your friends that you can give to teens. We have them that say, ask your kids that you can give to parents. We have them that say, ask your residents that you can use in your long-term care facility. And they serve as a reminder of what the questions are so that people can ask their coworkers and their loved ones and their clients. And the Air Force has gone the farthest towards this all-in approach. They not only trained all of their medical staff, But they also gave one of these cards to every wingman and to their spouse so that they can look out for their battle buddies and look out for their loved ones. And when we link all of these systems together with a common tool like the Columbia, we create a safety net that will catch those people who are suffering in silence. So for example, a school counselor used the Columbia to identify that a fourth grade boy was suicidal. He was sent to mobile crisis services who confirmed those results, sent them to the hospital where they provided counseling and safety planning. And it was facilitated by each touch point using the common language of the C-SSRS. All of the first responders in the state of Connecticut, for example, have one of these sticky pads that you see here that has a QR code on it that links them to community resources. And they can use the Columbia to screen in the field. So preventing suicide requires identification, and the Columbia tools are how we do that. The Columbia was developed about 15 years ago as part of a National Institute of Mental Health study looking at adolescent suicide survivors who had made a suicide attempt, and what was helpful for them after release from the emergency department. Up until that time, there had never been a study looking at adolescents and what was helpful for them. And it was developed by some of the top researchers in suicide at the time. Since that time, there have been thousands of studies using the Columbia. It's available in almost 150 languages now. It's endorsed, recommended, adopted, or mandated by many national and international agencies, and will help you reduce suicide, reduce your workload, and reduce your liability. And we'll talk about all of those things in a minute. Now, the definitions that the Columbia uses have been adopted by the Centers for Disease Control, and they have a document for suicide surveillance and give the definitions and a link to our website. But they also have a list of the words we should stop using. Things like completed suicide and successful suicide. You complete a project and you're successful at your job, and we want to take those positive words away from an act like suicide. And so the recommended language now is to just say someone died from suicide or someone ended their life by suicide, and to leave out any kinds of judgmental or other descriptive words when we talk about suicide. So this is what the screener looks like. It is 6 questions. The first 5 are on ideation, and they increase in severity. They start with, have you wished you were dead or wished you could go to sleep and not wake up? And then, have you actually had thoughts of killing yourself? If question 2 is no, you'll skip to question 6. But if question 2 is yes, you'll ask, have you been thinking about how you might do this? Have you had these thoughts and had some intention of acting on them? And have you started to work out or worked out the details of how to kill yourself? And did you intend to carry out this plan? You can't have a method in mind or intent to act on your thoughts if you've never had those thoughts before, which is why you can skip 3, 4, and 5 if question 2 is no. And then we ask question 6, have you ever done anything, started to do anything, or prepared to do anything to end your life? And there are examples of these different types of behaviors right on the form for you. Now, the important time frames that we ask about are the past month for thoughts and the past 3 months for behaviors. So if you have a yes to question 4 or 5 in the past month, you're at high risk. Or if you've had any of these behaviors in the past 3 months, you're at high risk. So let's see a demonstration video of somebody asking these Columbia screener questions to someone.
Okay, Amy, you mentioned you've been having a hard time. I'm going to ask you some more questions about that, okay?
Okay.
So, in the last month, have you wished you were dead or wished you could go to sleep and not wake up?
A little bit, I guess.
A little bit. And along the same lines as my last question, have you thought about actually killing yourself?
What do you mean?
Okay, let me rephrase. Have you thought about doing something to end your life?
Oh, doing something. Yes.
Okay. Well, thank you for sharing that with me. That must be very hard to struggle with those thoughts. Tell me, have you thought about how you might do this? Okay. I know it isn't easy, but could you tell me a bit more?
Sometimes I think about just walking onto the road, into the cars.
Okay. And when you've had these thoughts, do you have intentions to act upon them?
You mean actually doing it? No. No way.
Have you started to work out the details of how you might walk into traffic, Amy?
What do you mean by details?
Have you planned the when or the where you might walk into traffic? This could be the time, the place, anything like that.
Sort of. The street my school is on, it's busy, especially when school lets out. So I guess I've thought a bit about that.
Do you intend to go through with your plan?
No. I've thought about it, but I wouldn't, do it, you know?
Okay, I have some more questions for you.
Okay.
Have you ever done anything, started to do anything, or prepared to do anything to end your life?
Like, what? Like, try to get a gun or something?
It could be something like that, or it could be something else. Wrote a suicide note, started to give away your favorite things to friends, went to the roof but didn't jump, anything like that?
Maybe. Once I hid a bunch of pills my mom keeps for headaches, but I wasn't really serious about it.
Did you take any of the pills that you hid? And that was within the past 3 months?
No. It was probably, I think I was 9, and I'm 12 now, so about 3 years ago.
3 years ago. Was that the only time you've ever done something like that?
Yes, that was the first time, and I haven't done anything since.
We've covered a lot of information today, Amy. How are you feeling after answering these questions?
I guess it feels good to tell someone.
I'm glad to hear it. I want you to know you're not alone. A lot of people experience these thoughts, and there are things we can do together to make it easier. You feeling okay?
Dr. K concluded administering the C-SSRS screener, and Amy is set up to get the care she needs to stay safe.
Okay, so let's see. Amy had a yes to question 2 and 3, and no to question 4 and 5. And she had a behavior, but it was older than 3 months. So she's at moderate risk, which means she doesn't need to go to the ER, but she does need a referral for mental health counseling, and they'll get her the help that she needs. So again, we worry about a yes to questions 4, 5, or 6. Those are high risk. They indicate that you need the most extreme next step. Usually it's staying with someone until mobile crisis or an ER can evaluate them for possible hospitalization. But one of the great ways the Columbia is helping is actually figuring out who doesn't need to go to the ER because they don't rise to the level of high risk. This is how a first responder might use, or a teacher or anybody else might use the Columbia to rule out going to an ER.
We received a 911 call from a woman named Joan who said she was upset and afraid she might kill herself, so I was dispatched to her location. I've been in situations like this before where it was really hard to tell if someone was actually in danger of suicide or not. Fortunately, I was recently introduced to C-SSRS, and I could use a few quick questions to help me decide what level of care she needed. Hi, are you Joan?
Uh-huh.
I'm glad you called us. We're gonna get you some help, okay?
Okay.
I'm going to ask you a few questions about your thoughts and behaviors over the past few weeks to help us better understand how to help you. Is that okay?
Okay. Am I gonna have to go to the hospital?
Let's just get all the information about what's going on first, and then we can talk about that. All right?
Okay.
Good. Have you wished you were dead or wished you could go to sleep and not wake up?
Yeah. I wish I was dead right now.
Have you actually had any thoughts about killing yourself?
No, I would never do that.
Okay. Have you ever done anything? Started to do anything or prepared to do anything to end your life?
I mean, once when I was a teenager, I wrote a note to my friend saying I wanted to die, but nothing recently.
Okay, thanks.
Okay, so just like Amy, she had an old behavior, which makes her at moderate risk. And moderate risk does not have to go to the hospital. So he could tell her, here's your local community mental health center. Do you see someone there? Do you want to call them with me and set up an appointment? I want you to take the 988 hotline number and you use that if you start to feel worse. But he doesn't need to go to the ER. And what happens when people go to the ER when they don't need to be there is it actually shuts them down from seeking care. Magellan did a study that showed that when EMS used the Columbia, they had an increased rate of voluntary hospitalization. And it's critical to optimize these scarce resources and decreasing unnecessary ED holds. Now, it's just as important to have flexible and innovative delivery as it is to have the right questions. So you can put these questions on posters, you can put them on the side of coffee cups, you can put them on your ID badges, on keychains. We have a clipboard that has the Columbia screener questions on it. There's also an app that you can download and from the App Store. If you search for Columbia Protocol, you'll find it. And this can be used to punch in the answers to the 6 questions, and it will tell you if you're at high risk, moderate risk, or low risk, and tell you what next step you should take. And you can customize this app to provide local resources if your local mental health bureau or your state wants to do that. We're currently working with Israel because they want to have a QR code that comes up that links to Israeli resources. So we can also work with you to do that as well. Now, screening is super important. If you picked up anything from the first part of the presentation, you know that we need to screen. And we have lots of opportunities where we could be screening, but we're not. We know that over half of people who die by suicide see their primary care doctor in the month before they die because they have a chronic medical condition. And 2 out of 3 adolescents who make suicide attempts will go to the ER for a non-psychiatric problem. And then we can screen more at times of higher risk, like when someone's transitioning from active duty to veteran status or having problems at home or gets injured on the job or has to relocate. So imagine if every school nurse, physical therapist, EAP was asking about mental health and suicide alongside with their physical questions. If we ask, we'll find those who are suffering in silence. If we don't ask, we're going to continue to lose people to suicide. And we know screening programs work. Dr. John Mann did a meta-analysis and concluded that screening resulted in lower suicide rates in adults. And this one study looked at elderly primary care screening and found they were able to better detect depression in the elderly. And screening programs work in high schools and colleges. This one screening program at Emory University took the entire incoming freshman class and sent them the Columbia questions and told them that if they have yes answers, they should come into the counseling center, and here's where you can come to talk about it. And what they found was that more students came into the counseling center during the year when they were under stress than in any other year, because they were given this common language and a connection and permission to talk about these issues. Now, there are still barriers to screening that include stigma, fear, and liability. People don't ask because they're afraid. If the answer is yes, they won't know what to do, but the Columbia tells you exactly what to do. And asking actually relieves distress and protects you against liability. Mental health attorneys have looked at the Columbia and determined that the Columbia, because it's the most evidence-supported suicide risk detection tool that we have, that it is the best tool that you can use and provide you with some liability protection, because people don't get sued for bad outcomes. They get sued for negligence, for malpractice, for not doing something. And most of the successful lawsuits after suicides that I've seen against schools have been successful when someone knew something but didn't do anything about it. There haven't been any where someone screened with the Columbia, took the appropriate next steps that they were told to take, and something bad happened. That doesn't happen. And we've been able to normalize screening and reduce stigma, which is saving lives in the US Army. So, you know, in the military, people used to have to go to a separate building for their behavioral health care. And there was a lot of embarrassment and shame in being seen going to that building. So they moved their behavioral health services from a separate building into their medical facilities so that you can come in and get mental health care alongside with dental care, for example. And they put the Columbia questions on a kiosk in the waiting room so that you're coming for any medical appointment, you get screened with the Columbia. And they were able to decrease suicide as well as reduce inpatient overnights by 41%, which saved them $30 to $40 million. And so this common language is an intervention in and of itself, because it literally can be medicine, because it shows you care. You know, Just Ask is more than just a screening intervention. This common language develops connectedness, which saves lives. And even if you're lucky enough to see a professional, it's likely only once a week. And so we need to check on our friends and coworkers and neighbors more consistently than that. We also help kids by helping ourselves first, just like putting on your own oxygen mask. And if you're flying and the plane loses pressure, you can't help your kids if you're not taking good care of yourself. And schools offer students the opportunity to build their resilience by developing caring relationships with teachers and school staff. The presence of a trusted, caring adult is often considered one of the most critical protective factors in a young person's life. And I can't overstate the magnitude of connection and using the Columbia as a common language for talking about suicide. You know, loneliness has devastating health effects that are equal to smoking 15 cigarettes a day. It makes it more lethal than heart disease and obesity. And so the Columbia Protocol is more than just a method to identify when someone is at risk. It's a framework for normalizing the tough conversation, reducing stigma around talking about suicide. That promotes connectedness, which is what people who are suffering from depression so desperately need to stay safe. Now, how you ask the questions matters. When you're asking these types of questions, the key to building trust and collecting accurate information is to stay in the moment, clear your mind, and free yourself of as many distractions as possible. Use positive body language. Keep your arms loosely at your side with your head up, your eyes connecting to the person in front of you. Stay attentive and responsive but calm. Use a steady and clear voice and listen carefully. Don't judge. And if possible, paraphrase or reflect back to that person the important details that you hear them say. And I want to share with you a short video by Brene Brown on the difference between sympathy and empathy, because it's empathy that our clients need.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So don't be afraid to ask these questions directly. Listen to the story the person is telling you. Tell them you're worried about them and ask them to come with you to get help. Show that you care. Be patient, but don't take no for an answer if they're at high risk. Avoid minimizing their feelings, trying to talk them out of it, or giving advice. And create safe and supportive family, community, and school environments. Remember, talking saves lives, and all it takes is one caring, compassionate person to take notice and start the conversation by offering hope and help. And that person can be you. This is how you can reach out to us. You can send us email at kelly.posner@nyspi.columbia.edu, or you can go to our website, which is cssrs.columbia.edu, where you can download all of the tools that I mentioned, the Columbia community cards, which you can modify by putting your own agency logo on it or your local hotline numbers. We want them to be as easy to use and customizable as possible. And you can also fill out a contact us form if you lose the email address and you want to get in touch with us. Just search on C-SSRS.